Alright, so today we will be discussing the Elimination, Urinary, and GU assessment for Skills Lab Nursing 100. This slide reviews the anatomy and physiology of the GU system. You can see that the kidneys are clearly there with the adrenal gland present, ureters, bladder, urethra, and the nephrons. The kidneys remove waste, toxins, and foreign matter from the blood. It promotes fluid and electrolyte balance, and they assist in maintenance of blood pressure, contribute to red blood cell production, and the metabolism of vitamin D. They also receive 25% of cardiac output, and blood reaches the kidneys via the renal artery. In this picture, we see the urinary bladder. So the actual muscle of the bladder is called the detrusor muscle, and the bladder temporarily stores urine and also contracts for urine release. The bladder holds about 600 milliliters of urine, and the first sense to void occurs at 150 to 200 milliliters of urine. As the bladder stretches, sensory impulses are sent to the micturition center in the sacral spinal cord to signal the brain the urge to urinate. The urethra in the female is about 4 centimeters long, and in the male it's 20 centimeters long. This decrease in length in females increases the risk for urinary tract infections. There are many factors that influence urination. Disease processes that affect urine quality and volume are one of three categories: pre-renal, which have decreased blood flow to the kidneys; renal, which is disease of kidney tissue; and post-renal, obstruction in the lower urinary tract such as narrowing of the urethra or weakened pelvic muscles. Diseases that can affect the ability to urinate due to loss of bladder tone and reduced sensation are diabetes mellitus, multiple sclerosis, and also BPH. Cognitive impairment and mobility issues also contribute to urination issues for patients and increase the potential for urinary incontinence. Diseases that lead to irreversible damage to kidneys lead to end-stage renal disease. The patient will exhibit signs and symptoms of uremic syndrome such as nausea, vomiting, headache, coma, seizures, and this is related to an increase in nitrogen waste in the blood. This then progresses to needing either dialysis or kidney transplant. Sociocultural and psychological factors are concerns for privacy needed and appropriate times to go. Stress and anxiety can cause a sense of urgency and frequency. With fluid balance, it's important to increase intake of fluid to increase urine production. With surgical procedures, there's a stress response that releases the antidiuretic hormone, which increases water reabsorption. Stress also elevates aldosterone levels that retain sodium in water. Medications can affect the kidneys and the bladder, and there are many that do. An example would be diuretics that increase the urinary output, anticholinergics, and antihistamines, which can affect the bladder's ability to contract, and also opioids. Diagnostic exams can affect the kidneys by placing fluid restrictions. On this slide I have some terminology for you to be aware of. Nocturia can be a sign of renal alteration, and usually the volume of urine is formed at night is about half. Polyuria is greater than 2,000 cc's of urine output a day. Olguria is decreased urine output despite normal intake, and it can occur when there's an increase in perspiration, diarrhea, vomiting, and also in early kidney disease. Anuria, which is no urine. Diuresis is seen an increase in urinary production. Often it's due to fluids such as caffeine. And nocturnal enuresis may continue up to 5 years of age. We expect potty training to occur with children between the ages of 2 to 3 years of age. So next we're going to look at urinary retention. It's the inability to empty the bladder properly. In a very severe case, you may see up to 3,000 milliliters in the bladder. Signs and symptoms would be complaints of feelings of pressure, tenderness, restlessness, and sweating. Urinary retention can be due to childbirth, surgery, obstruction, medications, and anxiety. Urinary incontinence is the involuntary leakage of urine. It can be temporary or permanent. Assess the patient for a history of obstetric trauma, pelvic organ surgeries, prostatectomy, any mental confusion, a spinal cord injury, and also for taking sedatives and analgesics. Dialysis can be short or long term. Peritoneal dialysis uses osmosis and diffusion within the peritoneum, acting as a semi-permeable membrane. The blood is cleaned of waste and excess fluid. A sterile dialysate remains in the abdomen for a period of time and is drained by gravity. With hemodialysis, an artificial kidney machine with a semi-permeable membrane removes waste and fluids. Dialysate is pumped through one side of this and the patient's blood through the other side via diffusion, osmosis, and ultrafiltration. The blood is then cleaned and returned. With organ transplant and replacement of the kidney, immunosuppressants will be taken for the patient for life. Some cultural factors to be aware of is African Americans have a higher prevalence of hypertension and chronic renal failure. Diabetes mellitus, there are increased rates with Hispanic females, and also resulting increased chronic renal disease. Urinary diversion is a diversion of urine from the kidneys to an abdominal surface. It can be temporary or permanent, and it involves separating a loop of the ileum. Ureters are implanted here and urine is drained via a conduit. It can connect to a pouch and would need an ostomy nurse referral regarding fit for the outer pouch and appliances. It's important to watch for skin irritation. And on this slide you see different types of urinary diversions. When assessing urinary elimination, you are noting the urine, you're looking at color. Is it pale straw, which is what you should be looking for? It is typically darker in the mornings. You're also observing clarity. If it appears to be more thick, it can indicate a high level of bacteria. You're also noting odor. When assessing voiding patterns, you're going to ask the patient the amount, how often, their ability to empty, and their sensation. Can they sense that they need to urinate? Other things to include in your assessment would be questions regarding discharging, burning with voiding, flank pain, any incontinence, and their typical fluid intake. With this, we see the landmark for assessment, and the costovertebral angle is on the lower back, and it's formed by the vertebral column and a downward curve of the last rib. You palpate in the costovertebral angle for tenderness. On the front picture, you see the symphysis pubis. If the bladder is distended, you can palpate above that and feel the distended bladder. Different diagnostic tests that relate to the urinary system. The first is BUN, and that looks for dehydration and renal failure. Typical value is 5 to 25. Serum creatinine, normal value is 0.5 to 1.5. It's a byproduct of muscle breakdown that is excreted by the kidneys, and it's used with BUN to indicate renal impairment. A urinalysis specific gravity looks at urine concentration and the patient's hydration. A urine culture checks for infection. Residual urine is urine that is in the bladder after a void, and is typically obtained either through a straight cath, where the nurse has then drained what's left from the bladder, or via bladder scan, which is an ultrasound of the bladder and identifies the volume left in the bladder. Creatinine clearance is a 24-hour urine sample. It looks at how effectively the kidneys clear creatinine. And then the final two rows are tests and studies to evaluate for functions and abnormalities. So the UA test, often called a dipstick, looks at different values. Typically, this is a clean. It's done midstream, and the patient is instructed to clean from front to back and initiate this urinary stream, and then pass a container into the stream of urine. It's about 30 to 60 milliliters is needed to obtain this. The first value you're looking at is the pH, and it identifies the acidity of the urine. Normal value is 4.6 to 8. Protein is looking for protein in the urine and can identify kidney damage. Glucose is identifying glucose in the urine, and you would see that with diabetic patients. Ketones are seen with poorly controlled diabetes mellitus and can also indicate starvation and dehydration. Blood is a potential indicator of infection. Also, it's seen when women are menstruating, and specific gravity looks at the concentration of the particles in the urine and essentially is assessing a patient's hydration status. The next thing we're going to look at is urinary tract infections. When caring for a patient that has an indwelling catheter, it is the nurse's responsibility to provide good catheter care, and also with insertion of urinary catheters to provide a sterile technique to prevent urinary tract infections. Females are more susceptible related to the shorter urethra. And it's important to remember that urinary tract infections do cause increased amount of retention of urine in patients, so it is important to be aware of that. Nursing actions to promote urinary elimination: stimulating voiding, such as running water, encouraging privacy and relaxation. Sometimes stroking the inner medial thigh can assist in stimulating a reflexive release of urine. It's important to maintain fluid intake, promoting up to 2,000 cc intake of fluid. Encourage emptying of bladder by having the patient use the restroom every 2 hours when awake, sitting on a toilet for females, and standing for men if that's their normal way that they empty their bladder. Preventing infection by encouraging the female patient to wipe from front to back. Medication is needed. An example of this would be Flomax, treatment of difficulty urination for enlarged prostates. And catheterization can be a straight catheterization, an actual Foley, or suprapubic. So we will now look at the next part of this video in the next module.